Obs Gynae. Yes, dear doctors, in this session, I collected around 25 to 30 questions which are very high heel topics for this coming NEET PG 2023. Dear doctors, in this session, mainly I am going to select very high heel topics, that is especially, dear doctors, very high heel topics, that is management of carcinoma cervix in pregnancy. That is a one topic I want to discuss in this session because we can expect one or two questions. That is the one thing. And liver disorders in pregnancy. Dear doctors, these two topics are most neglected by you all because you people are busy in reading preeclampsia, diabetes, antepartum hemorrhage, postpartum hemorrhage, and you people are very least concerned for what these two topics. That's why in this session, special concern on these two topics. Now, doctor, I'm going to pose two questions on management of carcinoma cervix. So, look into the first question, dear doctors. A 30-year-old Primi gravida visits to routine ANC OPD with complaint of abnormal vaginal bleeding PV at 10 weeks gestation. USG reveals positive intrauterine pregnancy and further workup with cytology reveals adenocarcinoma in situ. Biopsy confirms invasive carcinoma. What is the next step? This is a one question. Okay, the choices for this question is classical cesarean section followed by radical hysterectomy at a term, medical termination of pregnancy, conization early in the second trimester, and chemoradiation. These are all the options available for this question. Now, doctor, come back to another question on the management of carcinoma cervix in the pregnancy. 30-year-old gravida 2 presents with spotting PV to labor casualty at 32 weeks. On per speculum, a cauliflower growth on the anterior lip of cervix was present. Further workup with biopsy reveals invasive adenocarcinoma. She underwent C-section along with radical hysterectomy. True statement is. So now if you take that, in the first question, she is 10 weeks. If you remember, she is 10 weeks. In the second question, she is what? 32 weeks. In the both the varieties, dear doctors, yes, diagnosed to be what? A carcinoma cervix in pregnancy. Now, doctor, look into this. So, first of all, before going to the management of carcinoma cervix in pregnancy, you should know how you manage the carcinoma cervix in non-pregnant. You all know all stages is chemoradiation, but till stage 2 even we will do surgery. You got the point, doctor? All stages we can give chemoradiation. Only till stage 2 even we can operate. Beyond stage 2A1, yes, chemoradiation. Understood? This is a dictum what you follow in non-pregnant. The same dictum also will follow in pregnancy stage. Now, doctor, look into this. So, for the management of carcinoma cervix in pregnancy, we will divide before 20 weeks, yes, then between 20 to 34 weeks and after 34 weeks. Please make a note of it. Before 20 weeks, 20 to 34 weeks and after 34 weeks. Now, doctor, if you come to stage 1A1 and 1A2, yes, we will do conization irrespective of gestational age. In stage 1A1 and 1A2, dear doctors, we will do conization. I think this point is very clear. Yes, yes. Now, come to 1B1, dear doctor, 1B1 to stage 4. Please make a note of it. 1B12 stage 4 before 20 weeks. If the period of gestation before 20 weeks, we will treat like non-pregnant state only. You got the point? We'll treat like non-pregnant woman. This is one thing you should remember, very simple, because you don't mug up the thing. Because if you mug up the thing, it is very difficult for you to remember in the exam. Understand? Before 20 weeks, from stage 1B1 to stage 4, managed like non-pregnant case. Yes, yes. Now, between 20 to 34 weeks, so from 1B1 to stage 4, please make a note of it, between 1B1 to stage 4, that to between 20 to 34 weeks. You got the point, doctor? I will discuss this point little later. If you come to more than 34 weeks, between 1B1 to stage 4, we will deliver by, doctor, we will deliver by classical cesarean. Then we will treat like non-pregnant. You got the point? You understood, doctor? So, before 20 weeks, 1B1 to stage 4, yes, we will treat like non-pregnant case. After 34 weeks from 1B1 to stage 4, yes, we will deliver the baby by classical cesarean. We will take an incision on the upper segment. Understood, no? So, we'll take a cesarean on the, we will take an incision on the upper segment of the uterus. So, that's why we'll deliver by classical cesarean and treat like what? non-pregnant case only. Now come to the management of carcinoma cervix between 20 to 34 weeks, that too from 1B1 to stage 4. Now doctor, look into these golden points. If the stages are operable stages, you all know 1B1, 1B2 and 2A1 is operable stage. We will give neoadjuvant, try to extend the pregnancy at 34 weeks, and we will do radical hysterectomy. Understood now doctor? So operable stages, that is 1B1, 1B2 and 2A1, will give neoadjuvant chemo, try to prolong the pregnancy by till 34 weeks, will deliver by 34 weeks, then we will do radical hysterectomy. In case of inoperable stages, that is 1B3, 2A2, 3 and 4, we will do hysterotomy, deliver the baby and chemo radiation. This table is for 20 to 34 weeks. This table is for 20 to 34 weeks. I think this is clear, doctor. Final take home message. Before 20 weeks, yes, you treat like non-pregnant case. After 34 weeks, we will deliver by classical cesarean, yes, then we will treat like non-pregnant case. Between 20 to 34, if it is operable stages, we will give neoadjuvant, we will try to prolong the pregnancy up to 34 weeks, we will deliver and we will do radical hysterectomy. If inoperable stages, yes, we will do hysterotomy, evacuate the uterus and we will give chemo radiation. I think this is very clear. Now doctor, look, what is the answer for this question? If you tell what is the answer for this question? So what is the answer for this question? Yes. So she is 10 weeks gestation, adenocarcinoma in situ. That is, yes, what is this? Adenocarcinoma in situ is a pre-malignant condition. So what is that? It is, yes, we will go for conization early in the pregnancy. We will go for conization early in the pregnancy. I think the answer for this question is clear, dear doctors. Yes. Now doctors, will proceed to the next question on the carcinoma cervix in pregnancy. Now doctor, look into this. She is 32 weeks. So what is the true statement? Patient should be delivered by lower segment cesarean to reduce blood loss. Definitely it is a false statement. Patient should be delivered by lower segment cesarean to reduce the tumor spread. Yes, it's a false statement. Patient should be delivered by classical cesarean to reduce tumor spread. Yes, definitely it is a true statement. Definitely it is a true statement, and you all know doctors, so pelvic lymphadenectomy mandatorily to be done. Here it is not recommended, it is also a false statement. The answer for this question is what, doctor? The third option. Answer for this question is what? Third option. Okay doctors, now we'll proceed to the next question. I think this is clear. Management of carcinoma cervix in pregnancy, very simple. Before 20 weeks, manage like non-pregnant case. More than 34 weeks, deliver by cesarean section, then manage like non-pregnant case. Between 20 to 34 depends upon the operable stages or inoperable stages. And you all know, doctor, all stages of carcinoma cervix is radio. I'm telling you non-pregnant. All stages of carcinoma cervix is radio sensitive, but before giving radiotherapy, chemo agent is given, making the cells receptive for radiation. That is chemo radiation. Means before giving radiotherapy, we will give 3 to 6 cycles of chemotherapy so that the tumor cells will become very receptive for radiation. That is chemo radiation. Until stage 2A1, we can operate. I'm telling you, till stage 2A1, we can operate. And any stage with tumor size more than 4 centimeters. Any stage with tumor size more than 4 centimeters. We have got 2 stages with tumor size more than 4 centimeters. One is 1B3, another one is 2A2. One is 1B3 and 2A2. You have to go for chemo radiation, no surgery. These are all the dictums to be followed in non-pregnant case. Same thing applicable in pregnancy also. Yes? Yes. Now come back to this question. So which of the following is true about obstetric cholestasis? Which of the following is true about obstetric cholestasis? So serum bilirubin increases to more than 10 milligram per dl. Yes. Pruritus usually occurs in second trimester, more during morning hours. It is not commonly seen in multifetal pregnancy. Serum bile acids is a more important parameter to increase and helps in diagnosing the condition. Now doctor, you have to remember 2 important liver disorders in pregnancy. One is acute fatty liver pregnancy and obstetric cholestasis. Okay. Here one question is based on the obstetric cholestasis. Now look into this question, dear doctors. A 24-year-old gravida 2 at 34 weeks visits to labor casualty with complaint of nausea, yellowish discoloration of eyes and urine since 5 days. On examination, serum bilirubin, dear doctors, serum bilirubin is 6 milligram percent, hemoglobin is 7.6 gram percent, platelet count is 62,000, RBS 36 milligram per dl. AST is 340, ALT is 260, peripheral smear shows normocytic normochromic. Diagnosis is HELP, obstetric cholestasis, acute fatty liver pregnancy, acute hepatitis. So what is the answer for this question, doctors? What's the answer for this question? So what is the answer? Yes, Dr. Ashimoto is answering option C. Any more answers? Dear doctors, any more answers? Yes, yes. Any more answers for this question? What is the answer for this? Yes, definitely it is acute fatty liver pregnancy. Acute fatty liver pregnancy. And doctor, I told you. So, what is the answer for this question? Which of the following is true about obstetric cholestasis? What is the answer for this question? What is the answer for this question, doctors? Some are answering option A, some are answering option C. Okay, waiting for your answers. Any more answers? Dear doctors, any more answers? So, okay doctors, now, okay, it's time for me to tell you the golden points on obstetric cholestasis and acute fatty liver pregnancy. Yes, now doctor, look into this. Here just I noted the points on obstetric cholestasis and acute fatty liver pregnancy. Now doctor, look into this. So, dear doctors, obstetric cholestasis, definitely the most common symptom is pruritus. Most common symptom is pruritus, especially more during night hours, and more on the soles and palms. And most common investigation or most common parameter helps in diagnosing the cholestasis of pregnancy is bile acids. And doctor, this cholestasis of pregnancy definitely usually more common in what? Multifetal gestation also. And doctor, another most important point in obstetric cholestasis, the serum bilirubin very rarely go beyond 5 mg/%. You should remember that point. In obstetric cholestasis, serum bilirubin very rarely go beyond what? 5 mg/%. And the liver enzymes will be within the range of 150 to 200. Now doctor, look into these points. So just quickly revise this. Most common symptom pruritus, most common investigation serum bile acids. Serum bilirubin very rarely go beyond 5 mg and will be within the range of 150 to 200. Now another liver disorder which is more important for the exam sake is acute fatty liver pregnancy. Now doctor, this acute fatty liver pregnancy usually commonly occurs in the third trimester. That too due to deficiency of LCHAD. What is the doctor? Due to deficiency of what, doctor? LCHAD, that is long chain 3-hydroxyacyl-CoA dehydrogenase. And another most important point, dear doctors, this acute fatty liver pregnancy more commonly seen in male fetus. One of the most common MCQ line. And so male fetus, it usually commonly seen. And doctor, you all know the clotting factors are usually synthesized in the liver. Due to acute fatty liver pregnancy, due to acute fatty liver pregnancy, all clotting factor synthesis will be deranged. That's why deranged coagulation profile, decreased fibrinogen level, and decreased platelet count, and decreased fibrinogen, decreased glucose level, decreased cholesterol. All these changes usually occurs in acute fatty liver. Now doctor, just look into this. Decreased platelet and decreased fibrinogen, decreased glucose levels, decreased cholesterol, and prolonged coagulation profile, prolonged prothrombin time, clotting time, and APTT. And liver enzymes will be in the range of 200 to 800. Understood, doctor? Yes, yes. Now, doctor, what is the answer for this question? So, what is the answer for this question? Definitely, you can see low blood sugar values. Low blood sugar values. So, that's why acute fatty liver pregnancy. And what is the answer for this question? So, definitely it is wrong statement. Pruritus commonly in third trimester. It is not commonly seen in multifetal, definitely seen in multifetal. Yes, serum bile acids is the most important parameter to increase and helps in diagnosing the condition. Is it clear, dear doctors? Yes? Yes or no? Yes, doctors? Yes? Yes. Okay, doctors. So now we'll proceed to the next question. Next question is waiting for you all. Yes. Now answer this question. Mother brings her 18-year-old daughter to the gynae OPD with complaint that she has not started having menses. Her FSH and LH levels are within normal range. General examination shows normally developed breast and pubic hair. On pelvic examination, vagina is blind and uterus is not palpable. What is the diagnosis? Dr. Prasad is asking, sir, how to differentiate between HELP and acute fatty liver pregnancy. Doctor, so someone is asking how to differentiate between HELP and acute fatty liver pregnancy. Anyone? Doctor, how to differentiate between HELP and acute fatty liver pregnancy? Yes, I am getting question from Dr. Prasad, how to differentiate. Doctor, in HELP also, there will be normal prothrombin time, normal APTT, yes, normal fibrinogen levels, and normal glucose levels. But in acute fatty liver, yes, prothrombin time is prolonged, yes, APTT is prolonged, fibrinogen is low, glucose is low. I think this is clear, Dr. Prasad. Dr. Prasad, is it clear? Yes? Yes. Okay, doctors, now come back to this question. Yes, what is the answer for this? So, she presents with primary amenorrhea, her FSH and LH levels are normal. So, general physical examination shows normally developed secondary sexual characteristics. On examination, uterus is absent. What's the diagnosis? What's the answer for this question? Dear doctors, what's the answer for this question? So, waiting for the answer. What's the answer? Whether it is Turner syndrome, Mullane agenesis, testicular feminization syndrome, Klinefelter syndrome. So, Dr. Ashutosh Gupta is answering Mullane agenesis. Any more answers? Doctor, any more answers? So, any more answers? Even if it is wrong, please come up with your answers. Dear doctors, even if it is wrong, come up with your answers. Even if it is wrong, come up with your answers. Okay, no issues. Now, doctor, look into this. Whenever a girl presents with primary amenorrhea, you will always examine for secondary sexual characteristics. Now, doctor, will always, whenever a girl presents with primary amenorrhea, the next step is examine secondary sexual characteristics. Now, if secondary sexual characteristic present and if secondary sexual characteristic absent. Now, if secondary sexual characteristic present, what is the investigation of choice? Doctor, if secondary sexual characteristic present, what is the investigation of choice? Please answer to the question. If secondary sexual characteristic is present, what is the investigation of choice? Batao, waiting for answer. If secondary sexual characteristic is present, what is the investigation of choice? Yes, USG. That too, why you will do USG, doctor? To rule out whether uterus present or absent. Now, doctor, if uterus absent, what all the diagnosis? And if uterus present, what all the diagnosis? If uterus absent, we have got two diagnoses. One is Mullane agenesis, yes, and another one testicular feminization syndrome or androgen syndrome, androgen insensitivity syndrome. Uterus absent, we have got two diagnoses, Mullane agenesis or testicular feminization syndrome or androgen insensitivity syndrome. If uterus present but still the blood is not coming out, she is not getting her periods, means something is hiding. Here the menstrual blood is hidden inside the uterus. Something obstructing the menstrual blood flow to go out. That is cryptomenorrhea. Cryptomenorrhea. And most common cause for cryptomenorrhea is what, doctor? Yes, imperforate hymen. Most common cause for cryptomenorrhea is what, doctor? Imperforate hymen. Yes, yes. Now, doctor, if secondary sexual characteristic absent, investigation of choice is FSH. If secondary sexual characteristic absent, investigation of choice is what, doctor? FSH. If FSH is increasing, it is ovarian cause. Please make a note of it. If FSH is increasing, ovarian cause. If FSH is decreasing, it is hypothalamo-pituitary cause. Hypothalamo-pituitary cause. Yes? Yes. And what is the normal level of FSH? It is 5 to 20 international unit per liter. If it is more than 20, definitely we will suspect ovarian cause. If it is less than 5, we will suspect hypothalamo-pituitary cause. Yes? Yes. I think this point is clear. Now, what is the answer for this question, doctor? Definitely Mullane agenesis. Okay. Now, we will go to the next question. Answer this. 16-year-old girl visits endocrinology clinic with complaint of what, doctor? Primary amenorrhea. She has got good secondary sexual characteristics with axillary and pubic hair. Examination of external genitalia reveals bluish bulging membrane and uterus is palpable on pelvic examination. What is the best management? Dear doctor, what is the best management? So what is the best management? Dear doctors, what is the best management for this? On perspiculum examination, they are going to reveal bluish bulging membrane and uterus is palpable on pelvic exam. What is the best management? Yes. Bhargav, Gayatri, Ashimota, Surbi, Prasad. Yes. Answer is we will go for cruciate incision and drainage of collected blood. And someone is asking what is pseudo-hermaphroditism. Doctor, the word pseudo-hermaphroditism is outdated now. Understand? So previously we used to use pseudo-hermaphroditism or intersex. Both the words are outdated. In place of this, we are going to use disorders of sexual development. So pseudo-hermaphroditism or intersex is removed. So now we are going to use disorders of sexual development. What is a disorder? If there is discordancy between chromosomal and genotypic and what phenotypic sex. If you know that, doctor, if it is XX karyotype, definitely the phenotype will be female. You got the point? If it is XX karyotype, definitely phenotype will be female. If there is for XX karyotype, if phenotype is male, there is a discordancy between the what? Phenotypic and genotypic sex. That is called as pseudo-hermaphroditism or intersex or disorders of sexual development. Yes? Yes, I think this is clear, doctor. Yes. Okay, now we'll go to the next question. Okay, so 30-year-old woman visits to IVF clinic with her husband with history of anxious to conceive since 6 years in spite of staying together and having unprotected intercourse. She evaluated with diagnostic histolaparoscope, TSH, prolactin, all tests shows normal. Her husband's aminogram report shows azoospermia. What diagnostic modality used to differentiate between testicular pathology and post-testicular pathology? So what is the answer for this? What diagnostic modality used to differentiate between testicular and post-testicular pathology? What is the answer for this? How to differentiate between testicular cause and post-testicular cause? How will you differentiate between testicular cause and post-testicular? Whether estimation of testosterone levels or estimation of FSH levels or karyotyping, none of the above. What is the answer? Dear doctors, what is the answer for this? How will you differentiate testicular and post-testicular? How will you differentiate testicular and post-testicular? Waiting for the answer. Yes, it is the estimation of FSH levels. Now, doctor, look into this. So, normally azoospermia can occur due to 3 levels, that is pre-testicular, testicular and post-testicular. Now, doctor, pre-testicular means defects lies at hypothalamus and pituitary. Pre-testicular defects lies at where, doctor? Hypothalamus and pituitary. Testicular defect lies at testis, and post-testicular, that is male ductal system. Now, azoospermia can be pre-testicular azoospermia, testicular azoospermia or post-testicular azoospermia. And you all know testosterone has got negative feedback effect on what, doctor? GnRH. Now, in pre-testicular, all hormones will be low. There will be decreased GnRH, which decreases LH, FSH, serum testosterone. Everything is low. That is hypogonadotrophic hypogonadism. That is in pre-testicular. In testicular, only testosterone is low. When testosterone is low, negative feedback effect on GnRH is lost, thereby increasing GnRH, LH and FSH. So, that is hypergonadotrophic hypogonadism. And in post-testicular azoospermia, which is also called as obstructive azoospermia, here everything is normal. Now, among these hormones, which hormone serves as a diagnostic test to differentiate between pre-testicular or testicular or post-testicular? It is the FSH levels. Dear doctor, it is the FSH levels. Yes, doctor, if FSH level increases, definitely it is testicular pathology. FSH level increases means definitely it is testicular pathology. If FSH is decreasing, definitely it is pre-testicular pathology, that is hypothalamus and pituitary pathology. If FSH is normal, that is post-testicular pathology, that is obstructive pathology, that is male ductal system. Is it clear? Is it clear, doctor? Yes? Yes or no? Yes. So now what is the answer for this question? What is the diagnostic test used to differentiate for testicular pathology and post-testicular pathology? What is the diagnostic test to differentiate for testicular and post-testicular pathology? Yes, it is the estimation of what? FSH levels. It is the estimation of FSH levels. Now doctor will go to the next question. Yes. Emergency contraceptive used in India. What is the emergency contraceptive recommended by Government of India which is supplied free of cost? Answer this question, Astosh. Yes. Kumari, Akash, Bhagya, Mithun, what is the answer for this? Emergency contraceptive used in India. Levonorgestrel 1.5 mg. Yes, Ulipristol 30 mg, Misoprostol 600 microgram, ethinyl estradiol 60 mg. What is the answer for this question? What's the answer for this question? Yes, I want some more answers. Yes, 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 very nice. Most of them are answering correctly. Yes, it is levonorgestrel, levonorgestrel. Now, doctor, few golden points on emergency contraceptive, which is also called as post-coital or interceptives. We used to use old method, that is USP method. We are no more using USP method. In this USP method, we used to use OCPs. Now the newer method is tablet levonorgestrel. What will give, doctor? How we will give this tablet levonorgestrel? Dear doctors, so tablet levonorgestrel 0.75 mg or 750 microgram will repeat the same dose after 12 hours. That is 2 doses of 0.75 mg. 12 hours gap within 72 hours, or a start dose of tablet levonorgestrel 1.5 mg. So now doctor, this 1.5 mg, yes, they have supplied free of cost by Government of India, and program name is Easy Pill. Program name is what, doctor? It is Easy Pill. Understood, doctor? So this is the new method. You got the total dose of tablet levonorgestrel will be 1500 microgram or 1.5 mg. Okay, yes. Now doctor, what are the other drugs for newer method? Ulipristol, Centromon, which is nothing but ormelofixivin, mifepristone, copper IUCD. What is the dose of ulipristol? Doctor, what is the dose of ulipristol? What is the dose of ulipristol? Waiting for answer. Dose of ulipristol. Yes, 30 mg. 30 mg. 30 mg. Okay, doctor. Now, most effective hormonal emergency contraception. Yes, it is ulipristol followed by levonorgestrel. Most effective emergency contraception overall is copper IUCD. Copper IUCD. Very good, Dr. Bhargav, Dr. Surbi, very good. Most effective hormonal emergency contraception is, first most effective is ulipristol, second most effective is levonorgestrel, and most effective emergency contraception overall is copper IUCD. Copper IUCD. Is it clear? Yes or no? Yes? Yes. So now doctors will proceed to the next question. We'll proceed to the next question. Yes. 28-year-old Paravan Livingman visits to family planning clinic for a routine checkup. She also gives history of copper T insertion 2 years ago, and further perspiculum examination shows that thread of the IUCD not found. Abdominopelvic X-ray was ordered and found to be IUCD outside the uterine cavity. What is the most next step in the removal of copper T? What's the most next step? Yes. Dear doctor, what is the most next step in this question? What is the answer for this question? Dear doctors, what is the answer for this? Yes, I am waiting for your answers. Yes, Dr. Bhargav has answered as a laparoscopy. Any more answers? Dear doctors? Yes, Ram Kumar, Ashimota, yes, Akash, Gayatri, Satyendra, yes, everyone has answered as option C. Very good, very good. Doctor, look into this. If copper T, doctor, if copper T, yes, copper T perforated completely into the peritoneal cavity, perforated completely into the peritoneal cavity. So we will go for what, doctor? Laparotomy. We'll go for laparotomy. Now partly, doctor, partly in the uterus and partly in abdomen, partly in uterus and partly in abdomen. Yes, we will go for hysterolaparoscopy, but preferred is laparoscopy, and answer is what, doctor? Laparoscopy. Yes, yes. Doctor, first investigation of choice for missed IUCD is what, doctor? TVS. Second investigation of choice is X-ray with uterine sound. Please make a note of it. First investigation of choice for missed threads is USG, and the second investigation of choice, doctor, second investigation of choice is X-ray with uterine sound, X-ray with uterine sound. First investigation of choice is what, doctor? USG, and second investigation of choice is X-ray with uterine sound. Yes, yes. Okay, doctors, next question. What is the answer for this question? 26-year-old primigravida refers to emergency labor ward with history of IBP reading, that is 190/130. She also gives history of blurring of vision, headache. On general physical examination, she has got grade 3 pedal edema. Duty physician advised the postgraduate to give IV loading dose of magnesium sulfate prophylaxis. Preparation includes, what is that preparation includes? Dear doctor, what is that preparation includes? What is that preparation includes? What's the answer? IV loading dose of magnesium sulfate prophylaxis. IV loading dose of magnesium sulfate prophylaxis. What is the answer for this? So 12 ml magnesium sulfate, 8 ml NS, 8 ml magnesium sulfate, 12 ml NS, 10 ml magnesium sulfate, 10 ml NS, 8 ml magnesium sulfate, 10 ml NS. What is the answer for this question? Answer for this, most of them are answering option A. Please think and answer. What is the answer for this question? Think and answer. What is the answer for this question? Think and answer. Doctor, look into this. IV loading dose. How much is the IV loading dose? Doctor, how much is the IV loading dose? 4 gram IV. IM means 50% magnesium sulfate. IV means 20% magnesium sulfate. Yes or no? IM means 50% magnesium sulfate. IV means 20%. Yes, yes. But in the market available is only 50%. Yes, and 20% is not available. Now, doctor, for 4 gram, we will take 4 ampules. So 4 ampules means, yes, 4 gram means it is 8 ml. Each ampule, doctor, each ampule will be 1 gram but 2 ml. 1 gram 2 ml. That's why 8 ml of magnesium sulfate. 4 ampules means 4 gram. Yes, that is 8 ml, which will be diluted with 12 ml of normal saline, which gives 20 ml of 20% magnesium sulfate. This is the dilution percentage for IV loading dose magnesium sulfate prophylaxis. Yes, is it clear, doctor? Very in simple words I told you. In the market, both IM means always 50% magnesium sulfate, IV means 20%. But in the market available is what, doctor? 50%. 20% is not available. Now, IV loading dose means definitely 4 gram means 4 ampules, that is 8 ml of magnesium sulfate, which is diluted with 12 ml of normal saline. So, total 20 ml of 20% magnesium sulfate. So, answer for this question is 8 ml of magnesium sulfate, which is diluted with 12 ml of normal saline. 8 ml of magnesium sulfate, which is diluted with what, doctor? 12 ml of normal saline. I think this is very clear. Okay, now answer this. 24-year-old gravida 2 visits to labor casualty with a complaint of right-sided lower abdomen pain and mild spotting PV after a period of amenorrhea of 7 weeks. Her general physical examination within normal limits. On per abdomen examination reveals mild tenderness in the right iliac fossa. Serum beta HCG is 3200. Serum beta HCG is 3200. TVS shows right adnexal mass of size 3x2 centimeter. What is the next step in the management? Doctor, so what is the best step in the management? What is the next step in the management? Doctor, what is the next step in the management? She is gravid at 2, comes with history of pain and mild spotting period at 7 weeks, hemodynamically stable, beta HCG is 3200. TVS shows right adnexal mass of size 3x2 centimeter. What is the next step? Doctor, what is the next step in the management? Waiting for the options, waiting for the answers. What is the answer? So I think some of them are answering option A, some of them are answering option B. So you can easily think, what is the management? What is the next step in for this question? Waiting for the answers. Waiting for the answers. Yes. Now doctor, look into this. Doctor, whenever the patient is, look into this, very important, whenever the patient is hemodynamically unstable, it is ruptured ectopic. Definitely what it is? Ruptured ectopic. So we will go for laparotomy. We will go for laparotomy plus self-injectomy. Because why doctor laparotomy plus self-injectomy? Because tubes are ruptured. Tubes are ruptured. That's why tubes are ruptured. So BP is low, pulse rate is high, hemodynamically unstable. We'll go for laparotomy plus self-injectomy. Now hemodynamically stable means it is unruptured. Hemodynamically stable means unruptured. So we have got 3 modalities. One is conservative. Yes. Another one is medical management and another one is surgical management. Now doctor, the golden indication for doctor, so look into this, the important indication, that too absolute indication, please make a note of it. Absolute indication for medical management is stable mother, yes, and yes, unruptured ectopic. Stable mother and unruptured ectopic. This is absolute indication. Relative indication, dear doctor, beta HCG less than 5000, yes, ectopic sac size less than 3.5 centimeter and no cardiac activity. These are all the absolute indications and relative indications. Now doctor, so please in the exam what you people will remember, you will remember more of relative indications, but you people will forget absolute indication. Absolute means yes, mother should be stable and it should be unruptured ectopic, and relative all this, beta HCG less than 5000, less than 3.5 centimeter and no cardiac activity. Now come back to this question. Here definitely ectopic sac size is 3x2, means definitely it is less than 3.5 centimeter, yes. And general physical examination is within normal limits, means hemodynamically stable, and beta HCG is also less than 5000. What more you want doctor for this question? What is the answer? Yes, definitely we'll go for medical management, that is single dose regimen, that is injection methotrexate 50 milligram per meter square. Single dose regimen, injection methotrexate 50 milligram per meter square. Yes, is it clear, dear doctors? Is it clear? Is this very simpler words? I thought the management of ectopic. Yes. So absolute indication means stable mother, unruptured ectopic. Yes. Relative less than 5000, less than 3.5 centimeter, no cardiac activity. Answer for this question is single dose regimen with injection methotrexate. Okay. Yes. Okay, now come back to this question. 30-year-old, gravid of 4, para 3, living 3, visits to family planning clinic at 7 weeks. Gestation. On TVS positive for intrauterine pregnancy with bilateral adnexa normal. She is requesting the family planning consultant for MTP pill. What is the ideal regimen is? What is the ideal regimen for this patient? Gravid of 4, para 3, living 3 at 7 weeks. She is requesting for abortion pill. Means she is in first trimester. What is the answer for this question, dear doctors? Misoprostol followed by mifepristone, mifepristone followed by misoprostol, mifepristone followed by methotrexate, misoprostol followed by methotrexate. What is the answer for this question? Dear doctors, waiting for the answers. What's the answer for this question? What's the answer for this question? Yes, yes, I'm waiting for the answers. Yes, come up with the answers. Dear doctors, come up with the answers. Yes, yes, most of them are correct. Doctor, look into this. In first trimester, yes, we have got following MTP techniques. One is medical abortion, very good. Another one, suction and evacuation using Carman's cannula. Suction and evacuation using Carman's cannula, and manual vacuum aspiration using MVA syringe. Manual vacuum aspiration using MVA syringe. So, among these three, the most common first trimester abortion technique is MTP. That is, most common first trimester abortion technique is what, doctor? Medical abortion. In this medical abortion, doctor, day one, we will give tablet mifepristone. Please make a note of it. On day 1, we will give tablet mifepristone 200 mg orally. On day 3, that is after 48 hours of tablet mifepristone, we will give tablet misoprostol 400 microgram orally or vaginally. But WHO recommends 800 microgram orally or vaginally. If you see, it's a combi pack of 1 plus 4 tablets. Understood, doctor? It is a combi pack of 1 plus 4. Means 1 tablet will be mifepristone and 4 tablets will be misoprostol. The topmost will be mifepristone and lower 4 tablets will be misoprostol. Each will be 200 microgram. That's why total will be 800 microgram. Yes? Is it clear? Dr. Bhargav is asking, what about expectant management in ectopic pregnancy? Doctor, look into this. When you will follow the expectant management in ectopic pregnancy means, if it is resolving ectopic, means in a question, means first golden indication for expectant management of ectopic is resolving ectopic. Means if the ectopic is decreasing in size. How you know that the ectopic is decreasing in size? Means we have to measure 2 values of beta HCG. If second value is lesser than the first value, definitely it is resolving ectopic. Means in a question, there should be given 2 values, and another after giving 2 values, the second value should always be lesser than the first value. Then only you have to go for expectant management. Is it clear, Dr. Bhargav? Is it clear, Dr. Bhargav? Yes? Yes. Now, doctor, come back to the, what is the answer for this? Yes, mifepristone followed by misoprostol in 48 hours. First we will give mifepristone, after 48 hours of mifepristone we will give misoprostol. Okay, doctors. Next, what is the appropriate size of the Carman's cannula to evacuate a pregnant uterus of 10 weeks gestation? What is the appropriate size of the Carman's cannula to evacuate a 10 weeks size pregnant uterus? What's the size of the cannula? Waiting for your answers. Dear doctor, what is the size of the Carman's cannula to evacuate a 10 weeks pregnant uterus? Hemant, Kumari, yes. Yashaswini, Ayan, Bhargav, Akash, Mithun, Prasad. What is the answer for this? What's the size of the Carman's cannula to evacuate a 10 weeks size pregnant uterus? So, what is the size of the cannula? Doctor, size of the cannula. Size of the cannula, yes, that too in millimeters, it is always corresponds to POG or POG minus 1. But commonly we will follow doctor POG only. If she is 10 weeks, 10 mm, 8 weeks, 8 mm. That's all, very simple. Yes. So, please look into this. Size of the cannula always corresponds to POG or POG minus 1. So, if she is 10 weeks, we will go for 10 mm. If she is 8 weeks, we will go for 8 mm. Yes? Yes. Now, answer this wonderful question. Second gravida female with history of twins in previous pregnancy 4 years back visits to routine pregnancy checkup at 36 weeks. She is sure of for dates. On obstetric examination, fundalite corresponds to POG. Abdomen is relaxed with presenting part 4/5 palpable. What is the obstetric score? One of the important question. What is the obstetric score? What is the obstetric score, dear doctors? Fundalite corresponds to POG. She is second gravida. They already told gravida with previous history of twins 4 years back. now presents with routine ANC checkup at 36 weeks. What is the answer? What is the obstetric score? Dear doctor, what is the obstetric score for this question? Yes. What is the obstetric score? I am waiting for your answers in the chat box, please. What is the obstetric score? Yes, yes. Most of them are answering correct. Yes. Yes, yes, Mithun, Ron, yes, very nice, very nice. Doctor, look into this. You have to know what is this gravida. Doctor, look into this. You should know what is this gravida. Yes, what is this parity. Now, doctor, gravida is nothing but it's a total pregnancies. It's a total pregnancies irrespective of POG and irrespective of outcome. Please make a note of it. It's a total pregnancies irrespective of POG and irrespective of outcome. Means irrespective of outcome is don't always expect gravida means live birth. No, it can be abortion also. Yes, it can be stillbirth also, or it can be live birth also. Whatever may be the outcome, whatever may be the pregnancy duration, how many times she is pregnant, that is total pregnancy, means it includes both present plus previous. It includes both present and previous. But what about parity? It is only previous pregnancies. Please make a note of it. Only previous pregnancies which have gone beyond 28 weeks. Beyond 28 weeks, irrespective of outcome. We can't say irrespective of POG, definitely we'll consider POG as a 28 weeks, irrespective of outcome. You got the point, doctor? Parity means only previous pregnancies which have gone beyond 28 weeks irrespective of outcome. Yes, means just previous viable pregnancies. Previous viable pregnancies. Yes, yes. And doctor, if previous history of twins or triplets, definitely parity remains same. Parity remains same. You got the point, doctor? If she gives history of twins or triplets in the previous pregnancy, definitely parity remains same, because parity is the previous viable pregnancy. It is not the previous number of childbirth. You should remember, parity is the number of previous viable pregnancy, not the number of previous childbirths. Understood? So now what is the answer for this question, doctor? Yes, gravida to para 1. Gravida to para 1. Yes? Yes or no? Dear doctors, is it clear? Yes? Yes. Now doctors will proceed to the next thing. Yes. Answer for this question. Lady was using OCPs past 7 weeks. Now she came with history of missed periods. Dear doctors, now she came with history of missed periods. Her UPT found to be positive. What is the method of estimating gestational age in this pregnancy? How will you estimate gestational age in this pregnancy? Because she became pregnant after stopping OCPs. How you want to estimate the gestational age? Dear doctor, how you want to estimate the gestational age in this case? The lady was using OCPs past 7 weeks. Now she came with missed periods. Her UPT was found to be positive. What is the method of estimating gestational age in this pregnancy? We'll assess gestational age by adding 7 days and 9 months to the first day of last menstrual period, or assess gestational age by adding 7 days and 9 months to the last day of last menstrual period, or assess gestational age by measuring crown rump length, or assess gestational age by clinical palpation of uterus. What is the answer? Waiting for the answer. Yes. I am waiting for many more answers. Yes. There are around 55 to 60 members in the chat box. I want answers. Only 10 to 15 answers are getting. Yes. What's the answer? She conceives after stopping OCPs. What's the answer for this question? Yes, doctor, I written one golden lines here. I request everyone to answer read this golden lines. In case of OCP use, ovulation may not resume immediately following withdrawal of hormonal pills, and there will be a delay of 2 to 3 weeks in resuming ovulation after stopping OCPs. Hence, EDD may not be accurately determined with Negle's rule. Hence, EDD may not be accurately determined with negligible. In such case, we'll go for dating ultrasound crown rump length and clinical examination findings for assigning the POG. You got the point? Yes, you know, because the negligible rule applicable for 28-day cycle and no history of OCP use prior to conception. Two things you should remember before applying negligible rule. One, regular cycles, that is 28-day cycle, and no history of OCP use prior to conception. If there is OCP use prior to conception, definitely we can't use negligible rule. We can't use negligible rule. That time we have to go for ultrasound marker of crown rump length or clinical examination of uterus. So what is the answer? Yes, assess the gestational age by measuring crown rump length on TVS. Yes, doctors? Yes, very good, nice. Nice, very nice question. 2 times repeat in INI-CET, 2 times repeat. You can look into this. Primary gravida with 38 weeks POG visits to emergency labor casualty with history of labor pains. She is sure of her dates. On obstetric per abdomen examination, detail reveals fundal height corresponds to term size. Contraction frequency 2 per 10 minutes, each lasting for 20 to 30 seconds. So presenting part is 5/5 palpable with subumbilical flattening. Fetal heart sound heard on the extremes of right flank. What is the position of the fetus? 2 times repeat question. I want the answers. Waiting for events. What is the position of the fetus in this question? Dear doctor, what is the position of the fetus in this question? First, what is the position of the fetus in this question? Whether it is right occipito posterior, brow presentation, transverse lie with dorso anterior, transverse lie with dorso posterior. Doctor, it is not anterior, dorso posterior. What is the answer for this question? Yes, waiting for the answers. Yes, please first, even if it is wrong, please come up with the answers. Yes, dear doctors, members in the chat box, yes, even if it is wrong, please come. It is 2 to 3 times same question repeat in the INI-CET. 2 to 3 question, yes, 2 to 3 years same question repeat in the INI-CET. Yes, what's the answer? Waiting for the answers. Yes. Yes, yes. Now doctor, I am going to explain in a line diagram. If you see this line diagram, now doctor look into this. Here is the occiput. If you remember, here is the occiput. Here is the occiput. Here occiput is towards pubic symphysis. If you imagine, here occiput, this is the diagram number 1, this is the diagram number 2. So now doctor, in the diagram number 1, if you see occiput is towards pubic symphysis. Whenever it is towards pubic symphysis, see the fetal back is towards midline. See the diagram in the diagram number 1. Fetal back is towards midline and fetal limbs will be towards flanks. You got the point, doctor? Fetal back will be towards midline. Yes, that is towards umbilicus, and fetal limbs will be towards flanks. And you can see the fetal cardia. Fetal cardia will be at spino-umbilical line, or fetal heart sound heard towards the umbilicus, that is in occipito anterior. Please make a note of it. In occipito anterior, fetal back is towards midline or towards umbilicus, fetal limbs are towards flanks, FHS are towards midline or towards umbilicus, that is spino-umbilical line, and there is no subumbilical flattening in occipito anterior. There is no subumbilical flattening in occipito anterior. Now come to occipito posterior. Here is the occiput. Occiput is in the sacral promontory, means fetal back is near flanks. Fetal back is near flanks and fetal limbs is towards umbilicus or towards midline, and fetal heart sound heard at the extremes of flanks. Fetal heart sound heard at the extremes of flank, and classical subumbilical flattening. Classical subumbilical flattening. Very repeat question. Very repeat question. I explained in very simple words this diagram. I think this is clear, doctors? Doctor, this is clear? So very simple line diagram I explained. Okay, occipito anterior, occipito posterior. You can look into this. Occipito anterior, subumbilical flattening is absent. Here is present. Fetal limbs are more towards what, doctor? Flanks. Here fetal limbs are more towards umbilicus. Fetal back is towards umbilicus. Fetal back is towards flanks. Here occipito anterior, fetal heart sound spino-umbilical. Here our fetal heart sound what? Towards flanks. I think what is the answer for this question, dear doctors? What's the answer for this question? Yes, here fetal heart sound heard in the right flanks, means definitely it is right occipito posterior. right occipito-posterior. Yes? Yes or no? Dear doctors, you're all happy? Doctor, you're all happy with the discussion? Yes? Dear doctors, you're all happy with the discussion? Yes. Now we'll proceed to the next question. Wonderful question, wonderful question. 26-year-old primea gravida allowed for normal vaginal delivery after 2 doses of cervi-prime gel induction. After delivery, she bleeds profusely. Placenta and membranes are delivered in toto. On per abdomen examination, uterus is flabby and fails to contract adequately after using 60 units of oxytocin and 800 microgram misoprostol, and also fails to contract with balloon tamponade. Patient shifted to OT. Which of the following arteries to be ligated to stop bleeding? What all the arteries you want to ligate? So, what all the arteries to be ligated to stop bleeding? What arteries? So, what arteries will be used to ligate to stop bleeding? What arteries you want to ligate? Waiting for your answers. Uterine artery, obturator artery, internal iliac artery, or external iliac artery, or ovarian artery. What arteries you want to ligate? Waiting for your answer. Yes, fast. What arteries you want to ligate to stop bleeding? What arteries you want to ligate to stop bleeding, doctor? Yes. Very nice, getting more answers. Very nice to see the answers. So now doctor, look into this. First we will try with uterotonics. Yes, following uterostonics till bleeding is plus, we'll go for mechanical methods. Following mechanical methods till bleeding is plus, we'll go for surgery. Now doctor, in the surgery, first we will do uterine compression sutures. Take down doctor, first we will do uterine compression suture, that is B. Lynch. First we will do what doctor? Uterine compression suture, that is B. Lynch, or we can go for devascularization surgery. Devascularization surgery means we will cut off the uterine blood supply. How will you cut off the uterine blood supply? We will ligate either uterine artery, yes, or will ligate either ovarian artery, or will ligate main artery where this uterine artery originates, that is internal iliac artery. That to which division is ligated? That to anterior division. Don't ligate the posterior division. If you ligate the posterior division, lower limb ischemia will occur and lower limb gangrene will occur. So, that is anterior division is ligated. Anterior division. So, these are all the arteries where we are going to ligate to stop bleeding. Understood? So, commonly used uterine compression suture is what doctor? B. Lynch. So, devascularization surgery, that is uterine artery ligation, ovarian artery ligation and internal iliac artery ligation. So, which division? Anterior division. Yes. Which is the preferred uterotonic, doctor? Oxytocin. Preferred uterotonic, that is oxytocin. Yes. What are the other uterotonics? We can use misoprostol. Yes. We can use carboprost. Yes. We can use methergine, that is ergot alcoholide. To treat PPH, 800 microgram misoprostol. To treat PPH, what is the dose of misoprostol? 800 microgram. And carboprost, it is 250 microgram intramuscularly to maximum of 8 doses. Yes. And in the exam they will ask you contraindications for methergine. Yes. Cardiac disease, we won't give. Rh negative pregnancy, preeclampsia, following delivery of first twin. So, these are all the contraindications for methergine. You should remember as a NEET PG aspirant. Yes. Doctor, you can expect 1 or 2 questions from both APH and PPH. Such a very high yield topic it is. Okay. Yes. Now, we will proceed to the next question. An intern conducts a delivery. In the immediate postpartum period, mother develops difficulty in breathing, tachypneic. On vitals examination, pulse rate is high, BP is low, tachycardia and hypotension. She suddenly collapses. Per abdomen examination and per vaginal examination is within normal limits. There is no excessive bleeding on per vaginal examination. What is the diagnosis? Now doctor, you can go directly, we can say it is amniotic fluid embolism. Doctor, two things you have to remember. In amniotic fluid embolism, the per abdomen findings will be normal and per vaginal findings will be normal. Yes. So minimal bleeding or no bleeding. Yes, that is the one thing, and per abdomen examination will be normal. But in uterine inversion, on per abdomen we can see a cup-like depression, and per vaginal examination a mass lying outside the vulva. Yes, you should differentiate like this. Amniotic fluid embolism, per abdomen examination findings will be normal, per vaginal examination findings also will be normal or minimal bleeding. But in uterine inversion, per abdomen you can see a cup-like depression, per vagina you can see a mass which is coming out through the vulva. That is the one thing. In PPH, doctor, in PPH, per abdomen uterus will be flabby, that is the one thing, and per vaginal we will see excessive bleeding. Per vaginal we will see excessive bleeding. Understood? Another important feature of amniotic fluid embolism is there will be cardiorespiratory derangement. Please make a note of it. Cardiorespiratory derangement will be there. Cardiorespiratory derangement. So answer for this question is what, doctor? Amniotic fluid embolism. Answer for this question is amniotic fluid embolism. Once again I am telling you, in amniotic fluid embolism, per abdomen examination findings will be normal, per vaginal examination findings will be normal. There will be cardiorespiratory derangements like tachycardia, hypotension, tachypneic breathlessness. But in PPH, per abdomen will be flabby uterus, per vaginal they can see excessive bleeding. In inversion of uterus, per abdomen we can see a cup-like depression, in per vaginal we can see a mass like coming out through the vulva. Yes? Yes. What is the answer? This is a repeat question from INICT. Nursing staff was conducting a delivery for a primea gravida in labor OT. Following delivery, nurse by inadvertently give the oxytocin direct IV bolus. Most expected complication to occur. Sir, your cover labor. Dear doctor, following delivery, nurse by mistake given oxytocin IV bolus. What complication is expected to occur in this? So normally oxytocin is given IV infusion. Please make a note of it. Normally oxytocin is given in IV infusion. Yes, and we should never give IV bolus and never infuse with 5% dextrose. So if you give direct IV bolus, what happens? Sudden hypotension. If you infuse with 5% dextrose, definitely it occurs what? Dilutional hyponatremia. So what is the answer for this question? If you give oxytocin IV direct bolus, definitely it will result in hypotension and cardiac arrest. Hypotension and cardiac arrest. Is it clear, dear doctors? Yes or no? So we should never give oxytocin IV bolus and never infuse with 5% dextrose, because if you give direct IV bolus it leads to sudden hypotension, and if you infuse with 5% dextrose it leads to dilutional hyponatremia. Yes? Yes. Now doctor, what is the next question? Yes. All of the following are risk factors for GDM except. One of the important repeat question from the INICT. All of the following are risk factors for GDM except. What's the answer for this question? All of the following are risk factors for GDM except. So history of unexplained fetal loss in previous pregnancy, history of macrosomia, GDM in previous pregnancy, PCOS in first degree relatives. So what is the answer for this? Doctor, what is the answer for this? All of the following are risk factors for GDM except unexplained fetal death, macrosomia, GDM in previous pregnancy, PCOS in first degree relatives. Which is not a risk factor for GDM? Which is not a risk factor for GDM? Doctor, yes, doctor, definitely unexplained fetal death, macrosomia, GDM in previous pregnancy, these are all the high risk population, but not PCOS. Doctor, it is not the PCOS in first degree relatives, it is the GDM in first degree relatives. That is risk factor, not the PCOS in first degree relative is risk factor. It is a GDM in first degree relative is a risk factor. You should know that. And here is a list of high risk women, that is a family history. I told you, GDM in first degree relatives, infections, maternal age more than 30 years, known case of PCOS, hypertension and obesity, persistent glycosuria, history of cardiovascular disease, HbA1c more than 0.5 more than or equal to 5.7%, and previous adverse obstetric outcomes. What are the previous adverse obstetric outcomes? That is, if there is history of macrosomia, history of GDM in previous pregnancy, history of unexplained fetal deaths or stillbirths, history of congenital anomalies or history of shoulder dystocia or nerve injuries. These are all the poor previous pregnancy outcome. These are all the high risk factors for GDM. These are all the high risk factors for GDM. So here look into this. PCOS definitely in first degree relatives is not a high risk for GDM. Yes, you should remember family history of GDM. Yes, that is a one thing. Another one, doctor, I told you, infections, maternal age more than 30 years and poor previous pregnancy outcomes. Okay, now doctor, 23-year-old gravida 1 presents to her physician at 19 weeks gestation with no significant medical history stating that diabetes runs in her family, and ECG is normal, urine analysis is negative for proteinuria, laboratory study shows FBS more than or equal to 126, HbA1c more than 6.5. What is the likely diagnosis? Doctor, what is the answer for this? So they were asking for whether it is a pre-gestational, gestational or maturity onset diabetes mellitus or none of the above. What is the answer for this question? So doctor, so we have got two varieties, GDM and pre-GDM. GDM and pre-GDM. What is the FBS cutoff for GDM? That is more than or equal to 92 milligram percent but less than 126. For pre-GDM it is more than or equal to 126 milligram percent. Please make a note of it. FBS will be more than or equal to 92 but less than 126 in GDM. In pre-GDM, FBS will be more than or equal to 126. That is the one thing. Then DIPSI cutoff for GDM more than or equal to 140. Here DIPSI cutoff more than or equal to how much? 200 for pre-GDM. And HbA1c levels, doctor, it is more than or equal to 6.5%. Here also HbA1c levels more than or equal to 6.5%. Now tell me what is the answer, doctor? Here FBS is more than or equal to 126, definitely it is pre-gestation, and any value of 200, random blood sugar value of 200, DIPSI of 200, definitely it is what? Pre-GDM. Is it clear, doctor? Doctors, is it clear? Yes or no? Yes. Dear doctors, is it clear? Any doubt in this question? Any doubt? No doubt. Okay, doctors, now we'll proceed to, so this is a diagnostic criteria. You all can see the diagnostic criteria. Okay, yes. Now we'll proceed to the next question, very important question. 28-year-old gravida 2 visits to ANC OPD at 30 weeks. She evaluated for her diabetic status in this pregnancy with 75 gram glucose load after 8 hours of fasting and started on insulin. After 2 weeks of therapy with insulin, her sugar values are well controlled. FHS is reassuring. What is the ideal gestational age for her delivery? I want everyone to answer this question. It's a repeat question. I'll be waiting for 1 minute. I want everyone to answer this question. What is the ideal gestational age for her delivery? She is GDM on well controlled with insulin. When you want to terminate? Doctor, she is GDM on insulin well controlled. When you want to terminate? She is GDM. Yes. Yes, when you want to terminate. Yes, Supriya, Akash, Akshata, Pragati. Yes. So I am getting most of the answers I want. Yes, I will be waiting for 1 minute. I want everyone to answer even if it is wrong. So please try for this question. Such an important clinical scenario question. Yes. What's the answer for this question? Yes, she is on insulin well controlled. When you want to terminate, what is the ideal gestational age for her termination? What is the ideal gestational age for her termination? Yes. Some more answers. Yes, even if it is wrong, please come up with the answers. Yes, even if it is wrong, please come up with the answers. Yes. Now, doctor, look into this. This GDM patients is this according to Priscilla White classification. GDM is divided into A1 GDM, A2 GDM. A1 GDM means only on diet. A2 GDM both on oral hypoglycemic agents or insulin. Understood, doctor? Now GDM, A1 GDM, that is well controlled on diet, will terminate around 39 to 40 weeks. That is beyond 39 weeks. Now A2 GDM, yes, well controlled on oral hypoglycemic agents or insulin, we will terminate around 39 to 40 weeks. But suboptimal control on insulin or oral hypoglycemic agents, we will terminate around 37 to 38 weeks. Now doctor, look into this table, very important. A1 GDM, well controlled on diet, yes, will terminate around 39 to 40 weeks, that is beyond 39 weeks. So A2 GDM, well controlled on insulin or oral hypoglycemic, we will terminate around 39 to 40. Suboptimal control will terminate around 37 to 38 weeks. Now pre-GDM patients with good glycemic control, no fetal distress, that is normal biophysical profile or normal Doppler, will terminate around 39 to 40. If there is fetal distress and poor glycemic control, will terminate around 37 to what, doctor? 38 weeks. You got the point, doctor? A1 GDM on diet, 39 to 40 weeks. A2 GDM well controlled with insulin or oral hypoglycemic agents, once again 39 to 40. Suboptimal control is 37 to 30. Pre-GDM well controlled, yes, 39 to 40. Yes, poor glycemic control, definitely it is 37 to 30. It's very easy to remember. And what is the answer for this question, doctor? Ideal gestational age for our delivery is how many weeks? Yes, 39 weeks. Ideal gestational age for our is how many weeks, doctor? It is 39 weeks. Yes, yes. I think you're all happy with this question. Yes, very good. Nice. We'll proceed to the next question. Wonderful question, which is a NEET PG 2020 question. So, which condition in the mother is associated with the given image of the fetal anomaly? Pre-gestational, gestational, intake of AC inhibitors, intake of sodium valproate. What is the answer for this question? What's the answer for this question? I am waiting for your answers. They given one anomaly of the fetus. What's the answer for this question? Anyone in the chat box? What is this fetal anomaly? Doctor, anyone in the chat box, what is this fetal anomaly? Doctor, anyone in the chat box, what is this fetal anomaly? Doctor, anyone in the chat box, what is this fetal anomaly? Yes, Sai Samran is answering. Yes, yes, very good. Yes, what is this fetal anomaly, doctor? I am waiting for the answers. What is this fetal anomaly? Yes, very good, Dr. Bhargav. It is caudal. Very nice, caudal regression syndrome or sacral agenesis or marmoid syndrome. What is this caudal regression or sacral agenesis or marmoid? Here lower limbs, that is both lower limbs fused together and appear single. Both lower limbs fused together and appear single, means both limbs fused and appear as a single limb. So you can see a single limb instead of having two limbs. And doctor, so this fetal anomaly definitely usually seen in pre-gestation. Doctor, look into this. If you have, we have two varieties of diabetes, pre-gestational and gestational. Pre-gestation definitely manifests in the first trimester, gestational definitely manifests in the third trimester. Once again make you clear, pre-gestational diabetes mellitus manifests in the first trimester, gestational diabetes mellitus manifests in the third trimester, that is referral time is 24 to 28 weeks. Now doctor, first trimester means definitely organogenesis is affected. That's why fetal anomalies or abortions are very common in pre-gestational. Understood, doctor? Fetal anomalies and abortions are very common in pre-gestational. And best marker used to assess fetal anomaly during diabetic pregnancy is HbA1c levels. Best marker used to assess fetal anomaly during diabetic pregnancy is what, doctor? HbA1c level. And what is the answer for this question? Pre-gestational diabetes mellitus. Pre-gestational diabetes mellitus. Yes? Yes. Very good. Okay, doctors, wonderful question. 26-year-old primary gravida visits to emergency labor casualty with history of spotting PV at 30 weeks. She also gives history of similar episodes of bleeding 2 weeks back. Emergency TVS done by radiologists and diagnosis of low-lying placenta is done. What's the definition for low-lying placenta? Very simple, nice question. 26-year-old primary gravida visits to casualty with history of spotting PV at 30 weeks. She also gives history of similar episodes 2 weeks back. TVS done, diagnosed as low-lying placenta. This is a repeat question from INICT. Doctor, this is a repeat question from INICT. I am waiting for the answers. So what is the definition for low-lying placenta on TVS? Doctor, what is the definition for low-lying placenta on TVS? Fast. What is the definition for low-lying placenta on TVS? It is placental edge within 1 cm or within 2 cm or 3 cm or placenta overlying the internal os. Please come up with your answers even if it is wrong. Yes, fast. What's the answer for this? Placental edge is within 1 cm, 2 cm, 3 cm, placenta overlying the internal os. Yes, doctor, yes, placental edge within 2 cm from the internal os. Placental edge within 2 cm from the internal os, definitely it is low lying. Yes, doctor, look into this. In older classification, we have got what, doctor? Type 1, type 2, type 3, type 4. Type 1 is low lying, type 2 is marginal, type 3 is partial, type 4 is complete or central. But newer classification, we have got only 2 types. One is, doctor, newer classification of placenta previa, we have got only 2 types. One is true placenta previa, another one is low lying. True placenta previa is nothing but placenta covering the internal os partially or completely. Another one, low lying. Low lying is placental edges within 2 cm from the internal os. This is a newer classification. You can look into this. I told you, newer classification. True placenta previa and low lying. Low lying means placental edge is within 2 cm from the internal os. Placental edge is within 2 cm from the internal os. That is low lying. This is a newer classification. And type 1, type 2, type 3, type 4, we are not using that. Yes? Doctor, is this clear? Yes or no? Yes. Now we will proceed to the next question. Yes. Wonderful question. 20-year-old Gravidad 2 visits to labor casualty with history of bleeding PV at 32 weeks. Emergency DVS done by radiologist and TVS report reveals as placenta partially covering the os. All of the following are true about her condition except, means it is the placenta previa. Yes. All of the following are clinical features of placenta previa except, which is not a clinical feature. All of the following are clinical features of placenta previa except. I am waiting for your answers. Even if it is wrong, please come up with the answers. Just another 5 to 10 minutes. I am going to end the session fast. What's the answer for this question? Fundalite corresponds to POG. Head is fixed and engaged. Head is floating and freely mobile. Painless recurrent vaginal bleeding. Which is a wrong statement here. Yes. Doctors, waiting for your answers. Which is a wrong statement. Dear doctors, which is a wrong statement? Yes, even if it is wrong, please come up with your answers. Yes, very nice. I am happy to see so many answers in the chat box. Very nice, very happy to see. Yes. Now, doctor, look into this. Very simple, very golden points on placenta previa. In placenta previa, it is a painless, causeless, recurrent bleeding. Why painless, causeless and recurrent bleeding means, if you take in abruption, there is, especially in the concealed variety, that is RP clot, that is a retroplacental clots, releases 2 things, that is thromboplastin and thrombin, which serves as a uterotonic agent, which increases the tone of the uterus. That's why it is painful vaginal bleeding. You should understand, in concealed abruption, that is retroplacental clots, releases thromboplastin and thrombin, which is a uterotonic agent, which increases the tone of the uterus. That's why it is painful vaginal bleeding in abruption. But in placenta previa, there is no uterotonic agents. There is no release of uterotonics, like no thromboplastin, no thrombin. It is painless, causeless, recurrent. That's why uterus is soft and relaxed. Fetal parts are easily felt because it is a relaxed uterus. But in abruption, uterus is tense, tender, rigid. Fetal parts are not easily felt. Understood, doctor? That is a one thing. Now, in placenta previa, placenta is covering the os, or placenta is in the lower uterine segment. That's why this placenta will prevent the fetal head descent into the pelvis. That's why fetal head is mobile and easily palatable, not fixed and engaged like in abruption. It is a mobile and easily palatable. You got the point, doctor? Look into this. And fundalite definitely correspond to POG, because in placenta previa, bleeding is always revealed outside. Whatever blood inside uterus, it is coming out. Means fundalite definitely corresponds to POG. Pallor is proportionate to blood loss. But in concealed abruption, the blood is collecting beyond the placenta. That's why fundalite is bigger for gestation age and pallor is out of proportion. Definitely it is true statement. Ed is fixed and engaged. No, it is a false. Ed is fixed and engaged in abruption. And ed is floating, definitely true. Painless recurrent vaginal bleeding, yes. Dear doctors, here is a differences between clinical features of placenta previa and abruption. I request everyone to go through these slides. I written very nicely, doctors. Please go through these slides. I told you, in concealed abruption there is RP clots which releases thromboplastin and thrombin. This consumes clotting factors which leads to activation of coagulation cascade leading to consumptive coagulopathy. DIC and acute kidney injury features will be the feature of abruption, and diagnosis is always clinical diagnosis in abruption and imaging modalities in placenta previa. And another one I told you, doctor, it is painless, causeless. It is painful vaginal bleeding because in abruption uterotonics are released, but in placenta previa no evidence of uterotonics. No evidence of uterotonics. Yes, yes. Okay, doctors. So, last question. All of the following are associated with covalar uterus except, we can see the covalar uterus. Doctor, this is a purplish dark spots on the serosal surface. So, this is a classical covalar uterus which is taken intraoperatively. Yes, in my duty I saw this case. This is actually seen in my duty. Yes. All of the following are true about covalar uterus except. Doctor, covalar uterus usually seen in concealed type. So, due to massive intravasation of blood into the muscular cords or up to serosa, it results in covalar uterus. Yes, it is seen in concealed variety associated with DIC and fetal death. When you see covalar uterus, yes, never proceed to hysterectomy. No indication for hysterectomy. Means covalar uterus per se is not an indication for peripartum hysterectomy. Is it clear, doctor? Yes or no? So, look into the potential image based question. Covalar uterus is a potential image based question. Now, few golden points on covalar uterus. It is seen in concealed type. Yes, massive extravasation of blood into the muscular cords up to serosa. There will be purplish dark spots on the uterus, that is Port Weinstein. Even hemorrhage can involve the broad ligament. And $1 million MCQ, doctor, covalar uterus per se is not an indication for peripartum hysterectomy. Covalar uterus per se is not an indication for peripartum hysterectomy. Yes, yes. Okay, doctors. I think, dear doctors, you are all happy with this session. Yes, dear doctors, you are all happy with this session. Yes. So, I have taken very high yield most expected questions from the high yield topics. Definitely this session just revise. And doctor, I am telling you, OBG has got great weightage in NEET PG 2023 because in NEET PG 2022 around 30 to 35 questions came from OBG. 30 to 35 same OBG. Yes, yes. Okay, doctors. So, anyway, all the best for your exam. Definitely this session would help you all. You are all happy with this session, doctors? You are all happy with some more? Yes, yes. Anyway, doctors, all the best for your exam. So, just revise. I am telling you, just revise. Don't read any new topics now. Only revision. And I am telling you, in gynec, especially concentrate on contraception, infertility, PCOS, amenorrhea and fibroid, AUB. That's all. And gynec oncology. And these are all the topics. I request everyone to look into these topics. In gynecology, dear doctors, concentrate on contraception, infertility, yes, amenorrhea, PCOS, AUB, fibroid, yes, and oncology, that too especially CA cervix, CA ovary and few aspects of CA endometrium. In obstetrics, concentrate on high risk pregnancies, that is diabetes, hypertension, yes, APH, PPH, yes, twins. Then another 3 important topic: abortion, molar ectopic, that is a one thing, and another iris pregnancy, RH negative pregnancy, yes you can expect, and labor obstetrics, take down doctor, labor obstetrics, labor obstetrics. These are the very few topics which is very important from the OBG subject. Okay doctors, definitely you are all very happy. I am going to stop in this session. Thank you doctors, all the best for your NEET PG 2023. All the best, God bless you all. Yes, thank you.